We've got a full house today. Welcome to you all, and welcome, of course, to our online audience that is also watching us. I hope you had a really fantastic time at the early parallel sessions. I was inspired, provoked, and gone away with lots of ideas to think about. So I hope you also had a good start to the day. We are calling this Reimagining Europe's Health Systems. And that is a co-creation. That is something that doesn't just come from the speakers, it will also be from you, the audience. And at various points this morning, I will be coming to you for your questions and your comments. I also have someone who is watching the online audience, so questions from online will also be very welcome. You are part of this conversation. So without anything further from my side, other than, of course, a warm welcome to everyone on behalf of Friends of Europe, I would like to give you an entrance to the imagination, because our first speaker, Boye Eliasson, is someone who's very well known in the health futures world. He has an extraordinary capacity to take the complex and make it inspiring and interesting and accessible and simple to understand. So, Boye, the floor is yours.
Thank you. Thank you so much, and thank you for the invitation, and thank you for being here. I guess there's a lot of expectation now. You did not warn me about that. So, yes. Do I get my slides? So, I did spend the last 11 years at the Copenhagen Institute for Future Study, leading health, where I've developed many of these concepts that I'm going to talk about. I am from the Faroe Islands, so one of the smallest societies in the world. Which is why anything that's bigger than 50,000 people, which is the population there, is just big, so it doesn't matter if it's 50 or 100 million, which is a benefit when you want to work in this way. So what I'm going to try to give with you on the future of health is opportunities and responsibilities, especially for Europe. EU as a global leader, I will touch a bit on, but really focusing on from what to how. So one thing is to define the what, the other thing is to do the how in that way. So here's just a picture of some old commercials. So the one on the left side is a commercial from the 50s in US. It states that you have to smoke Camel in order to be a good doctor. And here is cocaine for today for kids 100 years ago, and cigars for curing asthma. Funny? Okay. But think for 10 seconds. What are you doing in the health system today that your kids and your grandkids and their kids are going to say, what were you doing? That's your task. Call me tomorrow with your answer. Okay. Approach here. Build health as the most important societal pillar. So that's what we want to do. Just imagine that you can do that. So benefiting patients, professional populations, and planet. But the purpose here is really to build dignity, equity, security, and prosperity with health. So health becomes a driver for something positive, not something to resolve something negative. Change the mindset. So when we have changes, it is because we suddenly think differently. It's not because we take technology from A to B to C. We change mindset of it. And we are really dependent on echoes of yesterday's mindset. That is our constraint that we need to deal with. We should not forget that we have done huge progresses over the last years. Life expectancy at least doubled. We have almost finished polio cases. Malaria is in half, and you can go on and go on. So we can learn from a lot of good cases. So in many things have never been better, but our sense is that it has never been worse. So, and we have threatening issues, and here the art is to think, what is the future we would want to have? Imagine what it is that would be good enough for us, and not just try to fix what we don't like. And this is really where we need to imagine what it is we want, and then work for it, build it. Here comes the funny thing. We have never had more funding, personnel, technology, knowledge, hospitals, data, and still we are on the verge of the biggest breakdown ever. So what is happening? Why do we have this disaster? It's a mindset crisis. It's not a money crisis. It's not an educational crisis per se. It's a mindset. So we need to move forward from a treatment regime. Today, we have somewhere between 85% and 90% in Europe as an NCD disease burden. The hospital system that has given us a lot was based on communicable diseases, accidents, and violence, all acute responses. What we need today are not acute responses. It's early intervention when we see the signs. So we also need to leave the notion of that you are sick or ill. That's a binary thing. You need to enter to keep people healthy. So when we look at this, we all want to cry. But there is a secret. Tears don't change the world. It's the mindset that does. So where do we really go from here? So if we have learned anything, is that it's the great changes of mind that makes our shifts. I love technology. I love to read it. I love to be a part of the technological development. But if you don't have the imagination, you will not be able to apply it where we need it. So here comes the fifth industrial revolution mindset in. First question is, are we doing things right? And are we doing the right things? Sounds easy, very difficult, right? Often we apply, as we heard yesterday at the dinner who were there, we apply fantastic technology on something that's already broken. And we all know that we need to rethink, so we begin to focus on, or get away from the late treatment to a health span. And secondary prevention, we have the knowledge to do. So when we have a chronic disease, start early, deal with it. We have knowledge to at least 90% of this challenge. So then when it comes to the fifth industrial revolution, we have the fourth one, which is on new biology, so genomics, omics, all of these things, data, digital functions, imaging, smart materials, but it has been a volume approach. As much data as possible, as much sequencing as possible, not on the outcomes. What do we want to use it for? Does anybody know how much of the produced health data we use? 3%. Probably we spend more money on paying for hosting data we don't use than rare disease. Okay? Priorities. So here we go towards the quality, really focusing on why do we want to use this? We have the technology, we have the knowledge, we lack the purpose. Where do we want to go? So this is really about rebuilding with purpose, setting the direction, and not forgetting that the future is exponential. It's not as we are used to. But one thing is certain. If you don't know where you're going, any road takes you there, but it's definitely not where you want to be. Right? We always move, but where do we want to go? So it's to change our mind and change our course. And here comes the next what if. That's the luxury of having been working as a futurist. You can be 3-year-old and just ask, what if? And the what if here is, what if we imagine that health was the most important pillar? So this is what builds equity, equality, fairness in society. It's the safety, security, and the inner resilience in a country, sustainable growth, prosperity, reduction of avoidable disease burden, which is the most important part, and we can build digital bridges really to push this forward. So this is a new way of saying, okay, why do we want to apply these things? But we can also apply it to sustainability. Health is the 5th biggest polluter. So if we reduce the burden on the health system, we actually become greener in many ways. So health should also be an active for society, not just for health in itself as we see it, or clinical health as we see it. And it is very simple, you all know it. Can we intervene earlier? It's not about using less money on the same person, it's when do you spend the money? And there we get it totally wrong today. So we are only going in when chronic disease is at the middle stage normally, when we know we should be at the healthy medium risk, at least at the later stage to go in. We have this knowledge, but we don't want to pay for it. Then the most crucial question here is, what are we aiming for? The best health system or the healthiest population? Yeah? All people would respond, of course, it's the population, and then you ask, okay, the last half year, your decisions that prioritize the population over the system were, and there's no answer, because we are incapable of doing that. So this is where we really need to change our mindset. So you could say that history really calls upon us, so we can move from this reactive sick care that we all want to do. We know that. So this is the how question. So how do we get into this proactive, more health span part of going forward? What we did in the Nordic health approach that we started in 2018 and really pushed the first phase in 19 was to say, okay, the trajectory will break down the Nordic systems. So what if we spend half of the money on primary, secondary, and tertiary prevention, and the other half on curative, because people will still be ill. So that's not the point is not that nobody should be cared for in the system. And then begin to balance it out and work with it. In the end, this is about reducing avoidable disease burden, which is at least 30%. 30% what comes into our hospitals. But it's also about using technology and knowledge we have, apply it. We have 90% of the things that we are asking for. So here we can go in and really push forward of Livelihoods P4 on personalized, preventive, predictive, participatory, and then add potential on the part and give this to the hands of the individual and saying, okay, let's help you to stay healthy. Because why should it be the hospital that is the only thing that is relevant for your health? That's disease management, it's not health. And this is what we also did. So this is before ChatGPT in 2019, where we built this humanoid model just asking, saying, okay, what if all the relevant data for a person, their personal data, their environmental data, so the exposome data, if we put that in the hand of the individual with some help of some digitization, AI in it, then how can we begin to work with the individual as a participatory part of also producing the data? Because the future is not gonna be happy with only static data. We need real-time data, fluctuations of data that come in, and there's only one that can produce that, and that's you. It's not the system, it's you. And then, of course, you need to aggregate that into a system, so that's what we call the sustainability system, where the individual produces back to the system that makes value out of it, and then it has to come back to the person in some usable way. And here is where Facebook is a good example. I'm not a fan of Facebook, that's not the point. But instant gratification. So make it usable each day, then people produce. If it's not usable for them, they will not produce it. So if we want what we preach, this is the price we need to work with. Is it easy? No. And of course, often we say, okay, this is too complex in technology in different ways. But we already have frames, for instance, with Beauchamp and Childress principles of biomedical ethics on autonomy, beneficence, non-maleficence, and justice. And if we add proportionality, then we should be there. But we need to remember that we produce data to protect and help people, not to buy cybersecurity devices. Okay? That's what we do today. So data is for use. Where we are trying to apply this is to say there are 5 pillars. So let's work with improved technologies reasonably, improved prevention, primary, secondary, and tertiary prevention, improved treatment, really apply and precise on it, but dignity and equity should be the drivers. That's what we really want to push on it. And of course, the sustainability comes into there. But health is also about prioritizing. We can't get everything. So what is it we want to do? We should also remember that we can decide a part of the future. We can frame what future we want, and this is what we really need to push forward in different ways. And we know that if we look at the 5th Industrial Revolution, we see, we see biology, digital data coming forward, and also smart materials and imaging, but we need to combine these things in different ways. And we forget that we have an increased speed, and the development is exponential, something that we in our brains have a huge difficulty in really moving forward. So the question for the future is not if we can do things. We can do a lot of things. I've been involved in genomics for the last 25 years and also seen that progress in that way. Right? The first genome that we got some 20, 25 years ago was $1 billion. And now you do it for 1,000, 800, 500. So the question is not if we can do something, but why we want to do something. How do we focus on that why question? What is the purpose of that? Our biggest challenge is leadership. It's not technology. So we need to grasp technical change, which is where we do something a little bit better, or we refine some things that we know, with adaptive change, where we totally change the way of approaching things and do it. What happens more often than not is that we love the adaptive ideas, but if you want funding, you need to put a technical mindset and business model on it, and that fails every time. So this is super specialization and system thinking together. I have probably met 5 people in my life who can master this at the same time. I'm not one of them. There's no education in this. There's no course, no university class. It doesn't exist. This is what we need to develop as well. Just to show here on, if we just put in on health as treatment services in the middle, cost much more than anything else in it, but we will move into prevention and early detection and consumer and health and wellness, which will probably not be inside what we today see as the clinical system. Why should it be? This is about population health. It doesn't have to happen at the hospital. It has to be regulated, yes, but it doesn't have to be there. So I do some of these things in movement health where we work in Latin America, Africa, and Europe, and soon in Africa. One simple example, hypertension, big challenge in Ghana. What do? We put a QR code on the wall in 400 pharmacies. Person goes in, download an app, take a picture, they get the blood pressure. If they're over the threshold value, they get automatically referred to a hospital. It's digital bridges. We didn't build a new building. We didn't invent anything new. We just connected things. So this is what we really try to do in those parts. And then I'm, of course, in a lot of different projects, respiratory health, especially with COPD, 3rd biggest killer in the world, no attention. We're building indexes on that. Gaia is an app for in underserved communities for pregnant girls or young women to help them with different ways. Improve is an IHI project on value-based health and patient-reported outcomes. And My Health in My Hands is actually an EU project based on our human model. And then the biggest one is what we're trying to build now with the Danish Health Science Cluster and Life Science Cluster and WHO Europe on really applying known solutions to Europe in that way. So if anybody wants to collaborate on that, you know where I am in that. And then going to Europe, last question, almost finished. I know it says 0. The ingredients in Europe are here. There are so many things that are very good in the European Union that we can build things going forward. There's also a European global health strategy. I don't believe that we will make a good health in Europe if we don't want to lead in the world. We need to do both of those things. So that's the courage in it. But what is the direction? What is it really we want in it? So health first. So see health as the most important societal pillar. So that's the European Health Union. NCDs, really focus on it. Secondary prevention, dignity, reimagine privacy. The analog privacy we put on digital doesn't work. We can use the human sustainability model, and then super specialization and system thinking is really what we need to push forward. So could our goal just be so simple as reduce the avoidable disease burden? We have the technology, we have the knowledge. I do this in different hats, as you can see. I'm part of the Robert Bosch Academy, Copenhagen Institute, World Economic Forum, World Health Organization. I co-lead the first ever private-public partnership approach with digital health outside of the hospitals. Phase 5 is a decentralized digital clinical trials approach where you monitor people and see how they work. And so just saying that there are a lot of these initiatives that we are trying to connect in different ways and always open to work with anybody who can push this forward. And I'm so happy that Friends of Europe are pushing this. Sorry, I talked 65 seconds too long.
That's perfect. Thank you so much, Boye. And I apologize, I didn't introduce you with all your affiliations. I thought your presentation would speak for itself, and it absolutely does. But you are the Executive Director of the Movement Health Foundation and previously the Honorary Fellow in Futures of Health at the Copenhagen Institute for Future Studies. And boy, you've given us a lot to think about, some really great messages. And one of them is, we have a lot of the tools that we need. It's about smarter thinking. It's about making sure that we're doing the right things and putting health exactly where we want it to be, using it as the societal pillar that will drive so much else. So you've given me a great bridge to introduce my panel, who will take this topic a little bit further. So let me invite to come up and join me Javier Padilla Bernaldez, the Secretary of State for Health for Spain, Andres Culla, who is the Vice Chair of the European Parliament Committee, Envy Committee, a European young leader, and a newly elected MEP from Hungary, and also a healthcare professional, a surgeon, so somebody with real experience. Let me also invite Sandra Orta, the General Manager for Spain and Portugal at Bristol Myers Squibb, to come up and join me. Anke van Es, the Head of the Hospital Patient Monitoring for the European region at Philips. And Elisabetta Zanon, the CEO of the European Cancer Organisation, ECHO. So welcome all of you to come up, and we're going to discuss this in a little bit more detail. And let me start by picking up the challenge that Boyer gave us when he said, what if health was the societal pillar through which we see everything else? So my question, Javier, to you is, how can Europe leverage its health sector to drive sustainable economic growth?
Thank you.
Go ahead, the team will switch it on.
Okay, thank you very much. Well, first of all is that I think that in many times in our history, health has been the pillar to build a society. For instance, after the Second World War, healthcare systems were built, and they were built in order to promote economic development by means of having a healthy labor force in order to be able to continue with the economic growth. So I think that first of all to really analyze the relationship between health and economics, one thing that we should be seeing is that non-communicable diseases that are the biggest burden of disease now in our lives, in our healthcare systems, non-communicable diseases are also communicable diseases. And this is counterintuitive, but they are communicated by means of economic and social conditions from parents to sons and daughters. And I think that this is something that should be in the core of our analysis in order to be able to change it. So we should be improving economic because improving economy will improve health, and improving health will improve economics. One of the things that will work best in improving economics through improving our health situation is working towards and moving towards universal health coverage. Guaranteeing that everybody is going to have access to healthcare, doesn't matter their economic situation, is one of the things on the grounds to build a European Union for health, on a war for health. Second thing is that healthcare systems should be one of the main things in the center through the triple win policies, the having wins in health, in environment, and also in economy. So all the policies on health should be working on these three levels: improving health outcomes, improving environmental conditions, and improving economic situation. The third thing is that so to health policies are driving us to an increasing and to a better economy, we should give stability and predictability. And I think that this is central when we are speaking from a European Union perspective. Now we are seeing how other regions in the world, especially when talking about pharmaceutical policy, for instance, are giving some contradictory signals related to pricing and financing from medicaments and so that. So I think that Europe should lead the stability and the predictability in order to this relationship between the economic sector and the health sector. And the last thing I would like to say is that the previous speaker was talking about we have been working on quantity, and we should be moving to quality and to qualitative indicators. So I think that to do that, we should be changing the way that institutions and the private sector and the patients are relating each other in order to create virtuous cycles. I think that we in Spain are trying to make some initiatives with that. We have been recently approved the Spanish strategy for pharmaceutical industry. So we want to move from a client-provider relationship to a more complex relationship when we recognize mutually from institutions and also to companies which is the role of each other in order to be how we can profit the whole society from a collaborative perspective between the companies and the institution. And I think that this should be a very concrete point to do. And to finish, I think that we should also, on the bad part, we could say, we should also recognize that health and economics are not always creating virtuous cycles. They are in many situations in a contradiction, and we were talking before about some advertisements, for instance, about smoking and the effect on health. And now, for instance, in Spain, we are trying to pass some legislation on the reduction on the new products for tobacco, and we know that we are facing economic barriers in order to develop this that we know that would be a motor for a better health. So we should also recognize that economics and health are not always relating each other in a virtuous situation.
Thank you very much, Javier. So again, we were challenged by Boya to think differently, explore our mindset, and you've said, yes, health is very important as an economic driver, but it's part of that balance with sustainability, with the environment, and I take that to mean not just the sort of physical environment, but the social environment in our communities, etc. But also you've said that it isn't always a win-win. You know, there are some industries and some parts of economic activity that are not supportive of health, and so we need to be aware of that and make sure that we drive things in the right way. Andras, let me bring you in, because you, a year ago, you were still working in healthcare, and now you're a politician here in Europe at European level. So how do you see the EU being able to support national health systems, many of whom are fragile or struggling? Now that you're in the Brussels bubble, what are the tools that could be used to support our health systems?
Thank you. Hello? No?
Try again?
Okay, we'll try.
Yes.
No.
Now I hear you.
And thank you for your question. Yeah, it is true that health systems in European Union are facing a growing pressure, growing challenges such as aging population, growing costs, shortages of healthcare workers, supply chain disruptions, and long-term under-investments and the consequences of under-investments. And these challenges are national in structure, but shared in nature, and that's where the EU can and should play a supportive role. And I say a supportive role because healthcare is a member state competence, and the tools of the EU are limited, but the COVID-19 pandemic really showed us that the problems are the same in many countries, especially in time of crisis, but not only in time of crisis. And it brought to life the Sant subcommittee and the HERA, and now the Sant is a full committee with full legislative power, and we started to realize that the problem's almost the same in every member state, so maybe there are space for the EU where can intervene and help. I would like to mention two things, because you asked about fragile healthcare system. I think one of the key factors when we talk about fragility is the shortage of healthcare workers. 1.2 million healthcare workers are missing from the European healthcare system. The average median age of primary care doctors in Hungary is 62 or 63. 35% of them already retired but still working. That what keeps our healthcare system alive. So we have to put our attention on this issue, and I'm very happy that the Sant and Employment Committee has a joint initiative report on healthcare workforce shortages. Is the first report, and but because it's not enough to secure our supply chains, find solutions for the critical medicines, because we see that many times we have shortages of critical medicines in the member states, and now with the Critical Medicine Act, I think it's a very good initiative, legislation to solve this problem, but it is only one problem, and the problems are much more complex. So we have to solve this problem. I think it's a cliche that we have to improve our competitiveness because we are lagging behind the US and China, and we are losing our best scientists and researchers. And if we lose the innovation, then we are dependent on other countries, a part of the world. So we have to focus on these issues, but still we cannot lose our focus on healthcare workforce shortages, because without healthcare workers, there will be nobody who can deliver the very advanced and promising care or medicines to our patients. So what can the EU do? I think we have to find that space where we can help for member states with supporting the new programs, the new projects or research centers. We have to solve the cross-border research problems and also the cross-border healthcare problems, especially because if you analyze the problem with the rare diseases, these are rare diseases, and there are more and more treatments for this, but these are very, very expensive, and sometimes in a small member state there is only 3, 5, or 10 patients, and it is impossible to have in every member state a dedicated center for this disease, for a particular disease. So we have to find how can we deliver the cross-border care with to have only 3, 4 centers in Europe and deliver the patients to the care center and not the center to the patient, because it's not achievable. And Bogi mentioned that that there are more and more therapies based on genomics and more specialized specific therapies, and this will result that every cancer and autoimmune disease at the end of the day will become a rare disease, because the therapies are so specific that they target that particular mutation that causes that lung cancer, and there are 300 of mutations, for example. So these are the challenges, but with this legislation like Critical Medicine Act, Medical Device Regulation, I know it has many flaws, but we have the revision, ongoing revision. We can support our member states, and with this new INI report on healthcare workforce shortages, I think we can send a very strong message to the Commission and also to the member states to work together and find a solution together, because now the eastern part of Europe suffers the most, but we'll see the same trends in western part in Germany. And I talked to cardiac surgeons from Germany that they told me that sometimes there is no other surgeon who can assist in a surgery, so they started to upskill the nurses to be an assistant during the surgeries. And I think it is a very strong message that how big is the problem, and it is just the beginning. And we have to find, Mr. Andrukaitis always said that it should be a EU competence, or at least a shared competence, the healthcare. But yeah, the problems are the same, and that's why we have to act on EU level. And sorry, I can talk about this for hours, but the time is limited, so thank you.
Thank you, Andras. And really interesting, you know, you went from working in healthcare to now coming into policy, and I'm going to open the floor in a moment to take questions. For you here in the room, it's the old-fashioned hands up. For my colleagues online, you'll be using Slido to send your questions. But before I do that, Andras, I mean, you came into politics with the hope of changing things. And I know you've only been here for less than a year. But are you hopeful? Now that you've got a sense of the toolkits, the policies, the legislation, are you optimistic? Was your ambition coming into politics, do you think it can be fulfilled? Because you clearly came in to make a change for frontline healthcare.
Difficult question, because when I jumped into politics, my goal was not to, I was not thinking at that time in EU level, but in Hungarian level, because I witnessed what the devastating situation in Hungarian healthcare system, the lack of basic tools. It happened to me that I had to perform an acute life-saving surgery at 2 a.m. and I asked for a basic device, and then the surgical nurse told me that, sorry, but we don't have that device. Because I asked why, and she said, because our hospital in a so big debt that the supplier just stopped to send devices to our hospital. And another day, few weeks later, I asked for a suture to reconnect the bowel system to make an anastomosis, and she said that, oh, sorry, we don't have that particular size and type of suture. And I just realized that I have to make decision to make it with a thinner or a thicker one, but none of those are the optimal solutions. And just realized that the problem is very huge. And when our party leader appeared, Peter Magyar, and he announced that he will open an application process for everybody to be an MEP candidate, I decided to send my application as 500 other Hungarians, and I was selected in a top 10. There was a second round, the public vote, and I won that round. People online could vote to decide the ranking. 95,000 votes we got, and I got 35,000 of them. So that's how I jumped here. But here, I'm. To say it honestly, I'm more optimistic after 1 year than I was before, because I see that how committed MEPs we have is in the Sound Committee, and finally the Sound Committee has the full legislative power, and the healthcare is a cross-party issue, and we are on many questions on the same page. And I know that the EU is big and sometimes very slow, and for example, the legislations are not always perfect, like the medical device regulation, but we can improve this, and at the end of the day we can help to our member states. So yes, after 1 year, I can say that I'm optimistic. I know that we cannot achieve everything in 1 day or one year, but I see the willingness in my colleagues, and together maybe we can make our healthcare systems better.
Thank you. And so it's great to hear that in your experience inside the institutions, we have perhaps the seeds of what Boya was calling for, which is a change in mindset, and to really position health as being strategic, important, and a driving force. Let me open the floor now. I've got time for 1 or 2 questions or comments if anyone wants to make an intervention at this point. And I'm also keeping an eye on my online audience, that for you need to be sending in your questions via Slido. Yes, if we could just get a microphone to this gentleman in the front.
Thank you. You said that you can influence the member states by being at the European Parliament. Explain me in detail, how do you do that?
But before you give up the microphone, just tell us who you are, please.
I am Roland Pochet from the Belgian Brain Council, BBC.
Thank you.
Yeah. One good example, for example, the European Health Data Space, and the member states have to implement the European Health Data Space, and it also motivates them. I cannot say that force them, but motivates them to improve the digital systems in their healthcare systems. And also with the Critical Medicine Act, the situation is the same. But also, I would like to bring here another aspect, and that's the trust in our healthcare system and trust in the EU. I know you are skeptic, but for example, in my member state in Hungary, we are losing trust in the EU. People are losing trust in EU institutes and this in the EU solutions, and also in healthcare systems. And showing them and talking what we are doing here and what we can achieve in the long term, it also can help to bring this trust back. And it's even more important that it sounds for the first time, but before I became an MEP, I was not only a medical doctor, but I had a health educational TikTok channel with 350,000 followers. It's 4% of the Hungarian population. And through this, I also can improve the trust and to put some pressure on our decision makers in Hungary. And now I will have an online debate with the Secretary of State responsible for healthcare in Hungary, because we push and we are raising questions and asking questions about the healthcare and the situation in the member states from the European Parliament. We also can put some pressure on the member states. So it's not only through the legislation, but as MEPs we have this soft power which really has an effect, and we as an opposition party could achieve many things now just raising these issues and talking about these issues. So we achieved many things in Hungary, because we showed that, sorry, that's the problem, and compared to the other member states, they have solutions why we don't have. And this soft power is much stronger than we think in first.
Thank you, Andreas. And you've demonstrated very clearly why you've become part of Friends of Europe's Young European Leader cohort this year, this vision of speaking directly to the population, engaging with them, and then using that to leverage political power. Javier, I wonder if you might like to also comment about the interplay between what happens at European level as a tool, as an influence mechanism, as a support mechanism, and the national level decision-making.
Yes, something that I think that is very important to us at the national level is what happens at the European level, like a way of gaining legitimacy for many of the things that we want to do at a national level. For instance, the last EBSCO approved, between the different health ministers, the recommendations on the free smoke areas, and this is something that can also be translated at a national level. But I think that also, on the other side, we should think about where European Union is present in the lives of European citizens. And I think that now that we are facing the negotiation for the next multi-year financial framework, we should try to identify which are these things at a health level. For instance, I want to name the European Reference Network or the Comprehensive Cancer Centers as an example of how to try to create networks in health that are putting into a relationship the different member states and that are affecting concretely the population and the patients. So I think that we cannot move from EU health integration to EU health security, just, like clapping, because I think that we should be seeing what we have been doing correctly at the European level in these last 4 years, and how to move it forward to strengthen this network that I think that are also affecting the normal population in their countries, and trying to increase their degree of identification with the European institutions.
Thank you. And I think if you take inspiration from what Boya showed us earlier, where he said that, for the new mindset, what we need is both systems thinking and specialization, because the future of healthcare is both highly specific, tailored, but also has to be more integrated. I think both of those speak to the added value of Europe, because leveraging the combined knowledge and scientific research to help get these breakthroughs on specializations, but also systems thinking is as you say, it's the networks, it's the coming together, what works in your area, can we try this here? So in both areas, Europe, I think, could be a springboard to help that. But now let me bring in some of the other members of the panel. Sandra, I'm going to ask you the same question I asked Javier, which is, and from your point of view in the private sector, how does Europe leverage the health sector to deliver sustainable economic growth?
Well, first, thank you for the invitation, for being here, for Friends of Europe to create this forum, for all of you to be here and have that discussion. I want to bring a clear perspective on the importance of seeing healthcare and investment in healthcare not as a cost, but as a true investment. It's very challenging sometimes, when we see healthcare investments as a cost, and we need to shift that mindset. Totally that mindset, so we can work on prevention as well. I'm going to give you some numbers, just what pharma brings in Europe. And across Europe, it brings 300 billion of gross net value. In addition to that is 2.3 million jobs directly from pharma companies. Then you need to add all the companies that add services to pharma. So it's a key growth asset, and it needs to become a strategic growth and pillar for the economy that we have in Europe, and definitely for patients. When I look at the investment and what it brings, a euro investment on an innovative medicines, it brings €5 savings in hospital costs. It brings €5.5 on productivity reduction. And sometimes we don't value that enough because the budgets are split. We have a budget for pharma drugs, we have a budget for hospital costs, a budget for surgeries, a budget for the workforce, and we are not integrated. And therefore, it's very hard to see how we can become efficient unless we think differently about those investments and the effectiveness of those. All of that, all those investments, what it brought to Europe is that in the last years we increased the survival rates of patients suffering cancer by 12%. And believe me, most of us with a longer expectancy of life will suffer from some type of cancer. When I look specifically in Spain where I live, I can see that we reduce the mortality of patients suffering cancer by 30%. That means on average is 2.7 years of life. And what's, someone that you love, that means a lot of time. In the case of melanoma, that goes to 10 years. Additional 10 years of life. That's what innovation and medicine can bring. Not everything is looking good, though. When I look at clinical trials and the investment that we have in Europe is declining significantly. 10 years ago, we were the second biggest region after US. Now, you know which one is the first one? China. Followed by? No, it's not US, it's Asia, including Japan. Third is US, and then it's Europe. From 18% of the investment that existed in clinical trials, now we are 9% in Europe. That's bad for all of us. First of all, for patients, and then for our economy. When I look at particularly Spain, for example, 10 years ago, we started working the opposite way, and we did a public partnership with regulators, with policymakers, with the Ministry of Health, with industry, to facilitate and make a regulation on clinical trials more agile in a way that we increase the number of clinical trials by 75%. And Spain is right now the biggest country in terms of investment in clinical trials in Europe. That we cannot give for guarantee. And what we need is to transform that so we can still be one of the top regions in investment on clinical trials. That goes to biotech as well. Only a quarter of new biotechs are established in Europe. In US, it's 65%. And China and Asia is increasing significantly. Yesterday, we were discussing as well companies in AI that are using AI. We are not there. We have a very little percentage. It's not even double digit. We need to encourage that changes. That brings to as well a situation where we need to ensure that then that investment in innovation gets to patients faster, not just through clinical trials, but through access to patients. And the weight indicator that just became available maybe a month ago, it shows that we still have more than 500 days between MA approval and access to patients in different countries. I'm proud, as a Spanish again, that we, and thank you, Javier, that we improved significantly the weight indicator in Spain. Other countries are improving the weight indicator. Still, we are above 500 in general. So what we can do about it? Well, as BMS, for example, we have a good, as an American company, we have a very strong presence in Europe. We have manufacturing facilities in 3 different countries. We have R&D centers. And we are further increasing the investment that we have, 400 more million in Ireland. We are establishing a new CAR-T facility in the Netherlands. So we want to be present. And we just signed, for example, with BioNTech, a 9 billion partnership to develop further innovation in cancer. Last year, end of last year, was with a Swedish company, BioArctic, for Alzheimer's. We need to change the mindset and how we work. We want to continue investing. And what we can do is, first of all, patent protection. We need to really value innovation and protect the innovation. We really need, and Javier mentioned that, is regulation predictability. That means clinical trials. That means as well AI regulation. It means that we need to accelerate access to patients of this innovation so we can work on prevention, incentivize all that investigation. And the only way to do it is through public and private partnerships, so that we can gain and we achieve what just Bogi said about system thinking is the only way that we can achieve. And Europe become again competitive and attractive for innovation.
Thank you, Sandra. Let me now bring in Anka, because you're the head of hospital patient monitoring for the European region at Philips. But of course, Philips is a company that also works around the world. So we heard earlier how much our health systems are struggling. And one of the core challenges is the shortages of healthcare workers. There's far too much for them to do, not enough of them. When you look at how Europe is doing compared to other parts of the world, how could we be more effective in our approach to innovating within our systems?
Yeah, thank you so much. And again, also thank you for all of you being here and actually taking the chance to discuss these important topics to also reimagine healthcare for Europe. Let me start with a little bit maybe a difficult message. First and above all, and that's a good message, the Europe health industry, and I'm now talking about medical technology, has always been in the forefront. So, what does that mean with figures? 8% of the patents registered in Europe come from health tech industry. So, it's an innovative industry that is there, employing 880,000 of employees and contributing 11 million to the trade balance. So that is good. The more difficult part of it is, though, that we have more and more difficulty to bring all this innovation to workable solutions in the Europe space. If we compare it to the world, and it's just a brutal fact, and I look at one of our recent innovations, then it took us 90 days to get FDA clearance in the United States. And we are now almost 1 year further, and we still do not have clearance in the European Union. Our experience is that it on average takes us 24 months in Europe. Put on top of that the mandatory requirement to recertify our health tech solutions every 5 years leads to, on average, a comparable higher cost, which is 5 times higher than in other sides of the Europe. And it's for this that we also see many medtech companies first launching their solutions in other geographies. And it's for this also that maybe priorities of other regions become higher on the innovation agenda of many health tech companies. Now, I'm a European citizen and leading hospital and ambulatory monitoring for Europe. And we are a market leader in this space. So I take pride and also responsibility to continue to invest in the most important challenges we see in Europe. And let's then move to the more, I would say, engaging side of it, where I hope these days will also go about. It's about how do we then reimagine healthcare? How do we then address the challenges that were brought here together? Currently, 1.2 million shortage of clinical staff. Andras, you reflected to it. We talk about doctors, we talk about nurses, we talk about midwives, and then I did not even count the people that work in hospitals for logistics. We need to give that attention. We need to give that attention by training, by improving also the working conditions, and also by building upon technologies, Bogie, that already exist, but also enrich that with new innovation, and then we talk about AI. Because what it is that this can do together. At Philips, we embrace and we work a lot around AI. That's obvious when you are in the monitoring space, talking about data and capturing data. And with that, we also would like to give time back also to those clinicians to spend with basically patients, but to also early identify things that are going on, so that you do not have to go into a very deep treatment process. Or, if people have had their treatment, to be able to go home and to be treated and monitored in a distance. We have a few examples where we worked also very closely together in close cooperations with hospitals and regions. You can think about the virtual patient avatar. It is an image of a human body that has been complemented to the normal way we look at monitoring, that shows you the image, and in 3 seconds, people can see what is going on with the patient, compared to 10 seconds when you look at the normal waveforms in monitors. And this makes a huge difference during surgery. It is also addressing really things like situational awareness, where sometimes in a surgery and difficult period of work, we overlook those things. Another thing, the monitoring solutions that we offer are able to actually automatically download the data to systems that can be used for data interpretation and driving more insights. And that automatic download is saving 8 hours of administrative workload for clinicians that they should spend with their patients. And last but not least, with our industry partners, because I call them industry partners, we're also working on smart healing environments. Think about being at an ICU. An ICU nurse is receiving 350 alarms a day per patient, of which 99% are false alarms. We've been able to manage with hospitals to reduce that to 40%, and that is a huge improvement, and also working on the sound and the stress that clinicians and nurses experience at the ICU. So, a big pledge for a stronger life science strategy, focusing on regulatory, funding and investment.
Excellent. Thank you very much. And as someone whose baby spent time in the NICU, I can tell you all the noise and the alarms that were just going off all the time was horrendous. So I'm glad to hear that there's also a patient positive part, as well as reducing the workload on the healthcare professionals. So thank you for that. I'm going to bring in my final panelist, Elisabetta Zanon, and after that I'm going to be coming to you for questions or a comment or a contribution. So be ready. Elisabetta, you're the CEO of the European Cancer Organization, and one of the sort of key legacy pieces of the previous mandate was the European Beating Cancer Plan and the Cancer Mission. So, what's your assessment of those? And as we start thinking about the next MMF, what are your recommendations based on the experience of these big, this is Europe at its best, doing big things? Please.
Thank you very much, and thank you very much for the invitation. Is this working?
It is, yes.
Yes, okay, great. So first, the Beating Cancer Plan has been a great initiative during the mandate of the European Commission. And what is really good of this initiative is the leadership. I think this is what has really made a difference. It's not just let's say, an approach of taking different initiatives, starting little things, but really bringing it all together within a coherent framework. So what is good of the plan is the holistic approach. It's looking at prevention, screening, early detection, treatment, quality of life, survivorship. So I say the key words is political commitment for me. And of course, the leadership of the former European Commissioner, but also of the President of the Commission, Ursula von der Leyen, was really a very important element to achieve this. We have seen a huge impact at national level. So this leadership at European level has shown the way at national level. We see, for example, countries which did not have a comprehensive cancer plan developing one. We see countries which already had a plan improving it, extending it. France extended it to 10 years, for example. So I would say big impact in terms of policies at national level. Of course, there are still huge disparities across Europe in terms of cancer mortality and incidence, and also in terms of policies which are implemented at national level to tackle this. But I say that we have seen some of these gaps narrowing. We see, for example, that today we have all EU member states, the 27 EU member states, being politically committed to gender-neutral vaccination in terms of human papilloma virus vaccination. And this is absolutely great. We see also a lot of pilot initiatives happening at the moment, for example, in the field of screening, new screening initiatives in areas such as lung, colorectal, gastric, which were, let's say, the last cancers in terms of recommendations at EU level for screenings. So these pilot approaches are being screened at the moment. Now the key question is what is going to happen with the next European mandate, let's say with the next multi-annual financial framework. We have a commitment going till the end of this current framework, but discussions are now starting looking at the post-2027 priorities. And of course, the current geopolitical situation has huge implications in all this. We see a lot of focus on defense, and rightly so, of course. We see a lot of focus on economic competitiveness, and again, rightly so, with all what happens in terms of tariff wars and, let's say, this more difficult geopolitical environment in terms of trade across geographies. So all this is absolutely essential, but my question is, where is health in all this? Of course, based on the initial intelligence that has been shared in Brussels, we know that we can probably expect in the Commission proposals, which should come out, I think, in the second half of July, we may expect a focus on competitiveness, competitiveness fund, which may also cover elements of health. We see also element of health under the preparedness fund, which is good. But I think it's really important to think about this holistic approach that the cancer plan has taken in terms of looking at all elements from prevention to survivorship and ensure that all this is well reflected into the next multi-annual financial framework. Of course, we are supportive also of a competitiveness approach being taken in the next multi-annual financial framework. Cancer is an extremely innovative area in terms of research and innovation. We see so many small biotechs and also large companies, of course, investing hugely in this area. And personally, I'm very, very worried about the current trend with clinical trials. As you rightly mentioned, Europe was showing the way some years ago, and we have seen in the field of oncology a significant drop in the number of clinical trials. Some data that I show, which maybe is not the same data that you have, but was released recently, shows that the number of clinical trials in oncology halved in Europe as a percentage, let's say, of the share of clinical trials globally, halved in 15 years. What does it mean for patients? What does it mean, of course, in terms of innovation, but ultimately, what does it mean for patients? Very often, cancer patients, the only hope that they may have, if they have already tried everything, is being enrolled into a clinical trial. So they cannot wait. They cannot wait for a therapy to arrive to market, to be licensed. They need to have access earlier. So for me, a key, let's say, element in terms of looking for the future is how we can improve access access to clinical trials for patients, also cross-border access. Because, of course, in some member states, it's easier than others to participate in clinical trials. People living in big cities close to large cancer centers, they can have easier access compared to people living in rural areas. So really looking at how we can make the most of the next framework to try to reach a good holistic approach in terms of prevention, patient care, in terms of research, innovation, and ultimately having a win-win situation for everyone.
Excellent. Thank you very much, Elisabetta. Now, as I promised, I'm going to open the floor, and we'll start here. Ricardo will give you a microphone, and I'm keeping an eye out on my online audience to see if anyone has got a question coming in via Slido. I see something has already arrived. Please go ahead. Yep, the team at the back will activate your microphone.
There we go. Thank you. And thank you for an interesting debate. First, I'd like to comment because Andres was speaking before, and I see this time and time again where, especially medical doctors, they go from MDs to MPs or to MEPs, and they go from being the trusted person in society to one of the most hated people in society. I was a member of parliament for 4 terms, and I'm a medical doctor, so I felt that also. And a call to everyone, I think, is that let's not put all of the politicians in the same basket. There are good doctors, there are bad doctors. There are good politicians, there are bad politicians. Putting everyone in the same basket is eroding democracy. And putting that criticism and the skepticism against those that are taking actually the huge risk of putting themselves exposed to political office in a time and age where less people are actually willing to do so, and a lot of good people prefer to stay either in the nonprofit sector or the private sector, I think is not contributing to the European project. And so a word of gratitude to all of those that do decide to step up and serve the populations. And we should support the good ones to make sure that we get rid of the bad ones. 2 questions very quickly. We've been hearing, because we're talking about going from myth to fact, we've been hearing, especially in the health field, a lot of people calling for changes in the treaties towards making health a greater responsibility at the European level, which would address many of the issues from clinical trials to rare diseases to cancer and so forth. But then when we go to the national level, we don't feel that much support from governments, from the member states. I would like to get a sense from your side, because we really need this guidance. Is it worth investing in pushing for that change? Or is it useless because the member states will never go for it? I think this is a very important question to clarify so we can focus our resources. The second thing on competitiveness that was mentioned and the changes at the European Union, the regions that are showing greatest capacity in terms of competitiveness and innovations are the ones that are building bridges between the private sector and the state. And the private-public partnerships play a critical role. In Europe, we have, especially at the European Union, it's very difficult many times for the private sector to work with the Commission, to work with the different institutions. Do we see in what is prospected into the future to make Europe more competitiveness, a greater acknowledgement of the need to work closer together? Thank you very much.
Excellent, thank you. Javier, I'm going to be coming to you to say, is there an appetite amongst member states to really open up the treaty? Because we need to decide whether to put time and effort in that. And other members of the panel, maybe particularly our private sector members, is there readiness? Do you find a partner on the other side from the institutions ready for public-private partnerships? Maybe that's how we do it. Javier, go ahead.
Well, thanks for the question and the comment. I think that before thinking about transferring or assuming different competences on health at the European level, we should see if we are in the condition of possibility of doing that. And I don't think if it's now the position where we are. I'm going to talk about a very specific member states competency that we are not even coordinating at a good level. It's the price and reimbursement. The national competent authorities on price and reimbursement, they have this group. They are working together, but we are seeing that now that we are talking about the Critical Medicines Act, we are not taking a look at what we can do at a national level when coordinating the different policies at the critical medicines level. The price and reimbursement initiatives are critical, really critical, in order to reduce the level of the shortages. So I think that we should take a look at what are the levels at which the high degree of coordination has led us at competence swipe of between member states and European level union. I think that all the regulatory system is an example of how increasing the degree of coordination leads us to assuming competences from at the European level, and where we should be trying to mirror this situation and increase the coordination. And I think the price and reimbursement, for instance, is a very, very concrete example. So I think that before thinking about swiping the competences from member states to a European level, we should see where we should increase the coordination, and when we arrive there, we will see if we can cross to another stage.
Thank you. And I'm just very much reminded by the challenge that Boya set us earlier, which is, what do we want to do? And then, then we will have a very clear path to go forward. And we need to perhaps also say, what's stopping us from doing it? Is it the treaty? Is it that there's a desperate demand by member states to do more and they're being held back by this treaty, that if only we broke those bounds, we could do it? Or are there other issues at play? Are there, jealousies? Are they sort of guarding, certain things that, somebody's telling me, is there money behind it? So I think we need a good analysis to say what's actually stopping us from doing it. Yes,
can I add a little thing? For instance, if we take a look at a different region, and the Latin American region, there are now ongoing debates on how they should structure the regulatory agencies. So if they should go to a model on one country, one regulatory agency, or if they should have a whole regulatory agency for Latin American and Caribbean countries. And they have very different opinions if you take a look at the degree of development of the different regulatory agencies. So, for instance, there are some voices in Brazil that say, okay, I don't want to have a common regulatory agency because I am going to downgrade my current standards. But some other countries are saying, okay, I want to have a regulatory agency in common because it's the way that I can upgrade the standards that I have. So the European Union is, there are very different degrees of the state of the healthcare systems in the different countries, and I think that trying to coordinate in order to integrate is the logical way.
Thank you. Andres, did you want to briefly say something?
Just a very short comment. The healthcare and health is one of the top 5 priorities almost in every member state if we ask the people. So I think from the citizen side, there is a need for this type of coordination, but because among the member states there are big differences, even how much they spend on healthcare system, how many percents of the GDP they spend, and also, so I think it is one aspect, because for some member states it would be even the question, expose the flaws in their healthcare system and how they underfund the healthcare system. From other member states, they are worried that it will cost, it will be a big financial burden for them to support the poorer member states. And also we have the populists in European Union who are saying that it is against the sovereignty of the member state and it should be protected, even it would help to our patients and citizens, because I think now it looks almost impossible even to talk about this, open the treaty, because many populistic politicians would use this to achieve something else, because if the door is open, they step in and they can to say that put some pressure and they want to use it for their advantage. But in the next 10, 15, 20 years, I think this will become a real question, because if we just check the cost of the healthcare system, the cost of new therapies, the aging population, the workforce shortages, and as I just mentioned before, it is the same almost in member states, and we cannot deal with this. It is almost impossible, I think, to solve these issues on member state level, especially in small member states. And yesterday we had a roundtable discussion, and one of our panelists said that there are small member states and there are member states who think that they are not small, or something like that. And I really like that sentence, because it is true. And in the next 10, 20 years, I think the situation will be very different, and this will, I really hope that we will still have the European Union, and if we'll have the democratic European Union with democratic values, this will be a real issue. Thank you.
Okay, thank you. Sandra, do you just want to comment on, the sort of readiness of the institutions to be a partner in public-private partnerships?
I definitely see an appetite, and I see good intentions as well, and some good examples. So, for example, yesterday just came up a proposal on the patent protection regulation that we worked together, that I felt that we've been heard. Maybe we did not get as far as we wanted, but I felt we've been heard. In terms of clinical trials, I think there is an eagerness that we are noticing that we need to improve, right? So we have few examples, and we are working on a reform. So I see an appetite. I think that appetite and that public and partnership needs to keep growing. And first of all, I think we need to build on trust, and we need to build on having the same priorities. Javier, for example, mentioned the challenge that we have in many countries, where we have a national healthcare system, but then the funding comes from the different regions. And that happens in most of our European countries. And the priorities might be different. Therefore, we might have a national healthcare system that then in their regions, there's inequalities of access. So we are still lacking. So there is an appetite, to answer Ricardo's question. I think there is. We are still a long way, so we can really make it happen. I see the attitude, though, and the eagerness. That's a good part.
Thank you. Can we just take the question that we had from Slido, because you may want to add to that. Please go ahead.
Hi. So from a participant online asks, how many pay for care, get no results, return sicker? Yeah, we call this integrated health in Europe. What does it say about our commitment to integrated people-centered healthcare in Europe?
I'm sorry, I didn't hear the first bit. How many what?
How many pay for care, get no results, and return sicker? Yet we call this integrated health in Europe.
I'm sorry, I didn't understand that.
How many pay for care?
How many people pay for their care? Right? Okay.
How many people pay for care, get no results, return sicker? Yeah, we call this an integrative health in Europe. And
Okay.
what does this say about our commitment to integrated healthcare, people-centered healthcare in Europe?
Okay, so I think we've got a question there asking about whether if people pay for health, and whether actually, I assume that's health systems that pay for it, or individual patients with their co-pays pay and don't get better. So perhaps we go back to the question that about holistic care, and we need much better prevention and promotion. So how many people are entering the health system and the outcome is not necessarily better health, and yet we haven't moved to this, integrated and holistic care. Is anyone on the panel want to pick up on that? Elisabetta, do you want to pick up on that?
Yes, I can pick up on that, but I would also like to comment very briefly on the issue of partnership, public-private partnership, which was mentioned before. And I think this is really very important, crucial. We do a lot of research in Europe. We have very good universities, of course. There is a huge amount of research, but not all the time, unfortunately. This research remains in Europe in being translated into innovation. Of course, we need to do several things to ensure that this will happen. But for me, one of the things which would be really important is public-private partnership to ensure that there is more collaboration between universities, clinicians, and also the private sector, so that ultimately we can scale it up also and bring this innovation faster and at scale to patients. Now, looking at the issue of out-of-pocket payments, what I call out-of-pocket payments, I think we have very different healthcare systems across Europe, but ultimately, even in the countries where you have national health services, and they are universal, they are for free, de facto, you end up having to co-pay something if you really want to have access to certain types of services, and you do not want to wait for a very long time. So personally, I don't see this issue of co-payments as something which is really a major barrier. I think this is really something which is a reality across Europe. Where I see a big problem, it's in terms of how to access healthcare in other countries, how you can receive specialized treatment, rare diseases in countries where a diagnosis for these rare diseases can happen, or you can have access to innovative technology which is not available in your country. So for me, this is really very important in terms of facilitating access rather than this issue of co-payments. Of course, there are different times in availability of therapies to patients across Europe, but this is something which maybe we leave aside for this debate.
And time is not our friend, because we're coming to the last sort of 4 or 5 minutes of our conversation. So I'm going to ask each of you to give us a sort of a final message, and in that, you could give us a message about how you would like the EU to position health in the multi-annual financial framework. Perhaps you might like to give us a message about, how Europe could make itself less vulnerable by reducing its reliance on external supply chains. Perhaps you'd like to give us a message about, political leadership, because that was put very strongly on the table. So any topic is open, but you've got 60 seconds each. So, Anke, can I start with you? Final message. You have the ear of the Brussels bubble and beyond. What would you like to say?
Yeah, so what I would like to say, and that is what I think was mentioned, we really need to do something about improving our competitiveness in Europe. And that is simple, in essence. We need to embrace, if we really want to change and reinvent healthcare, we need to embrace, also in Brussels, medtech. Medtech is essential to help driving systemic change in healthcare. It's an industry that can help streamline your workflow and to also unburden your health system. That means that also in that reality, it is super essential that we move from a box type of purchasing approach towards value-based procurement, where we look at the value that the solutions bring and how it helps to actually reimagine your healthcare system.
Thank you. Sandra.
I would build on what Angel has said, and I think investing in innovation, it could be in pharma, in biotech, in medtech, brings better health. Better health brings higher productivity. Higher productivity will help us to go back and continue investing in innovation. The only way to do that is through private-public partnerships, so we can really reach and change the healthcare system with system thinking. Now we have a window of opportunity. The international environment will give us this opportunity. We cannot lose it. We need to become much more attractive to attract that investment and attract and retain that talent.
Thank you. Andres.
Thank you. I would like to choose a bit different perspective and start from a step further that for us here in European Union and European Parliament, it's not enough to work on these issues and find the solutions, but it is very important to communicate this, to show our citizens in our member states what we are working, what we are doing here, because these extremists and populists are more and more vocal and more stronger across Europe, and there is a real. They are a real threat for for the democratic values and for the future of the whole European Union. And if we are not telling our voters, citizens, what we are doing here, what are the advantages to have the European Union, then it can easily happen. Then 5 years later, we are not talking about how EU can solve these problems, but how the member state can solve it, because there is a real chance that these populists start to disintegrate the European Union. So I think it is very important to think about it and not take granted the trust of our citizens, and we have to explain every day and communicate every day what we are doing here, what are the advantages, because for us it is very easy to see, but for them who are living in rural areas or small villages where people have absolutely different problems, everyday problems, how they pay for the food, how they buy a new backpack for their kid to go to the school. We have to show them what we are doing here and how we can help, and even we cannot help immediately, but what are the positive consequences in the long term. I think it is very important, because the world is changing, and it is very difficult to build these systems, but very easy to destroy them.
Thank you. Elisabetta.
Yes. When we look at health, this is really a priority for EU citizens. We see that in Eurobarometer's surveys. Regularly we have health as probably the top or one of the top priorities of EU citizens. What is Europe doing in health now? What can it do in the future? I think that we really need strong leadership to ensure that we can do as much as we can do in the current treaties. Of course, the changes of the treaties, this is something which is very difficult to achieve, but there is still possibility to do a lot in the current framework if there is the political will of doing so. I think the cancer plan has really demonstrated what can be done at European level when there is political will, and the repercussions that these initiatives can have at local level, regional level, national level. So let's continue in this direction. Let's ensure that the work started with the Beating Cancer Plan can continue and be completed, because of course we don't fight cancer in 5 or 6 years. We need a much longer period of time, and let's use it as a model for other disease areas for more action at EU level in health.
Thank you. Javier.
Thank you. Well, first of all, is considering health as a possibility condition for economic development and considering the increase of the network organization and cooperation between the member states at the European Union level at the possibility condition for legitimacy of the European Union institutions. I think that we should ask member states and European Union institutions to have like a long-term sight, and there have been many things that have been done very correctly during the last years, and they should not be just removed and changed by all the trending topics at the European Union policies. So I think that this is something that we should be very clear and increasing the network cooperation. And the last thing is about leadership. And I think that leadership cannot be like imposed and cannot be only performed, but should be like materialized. And I think that the European institutions, when COVID-19 and the vaccination process really showed how they really could work in an integrated way so that member states were receiving the vaccines not because the income their citizens had, but because they were members of a common institution. So I think that this should be like the model we should try to inspire us at the leadership we want for European institutions.
Thank you. So thank you to our panel, to Javier, to Elisabetta, to Andres, to Sander, and to Anke. We started off with Boya setting out some big challenges to think differently and address a new mindset, and to remind us that all the money and the effort and the technology we're putting in the table, if we use it to try and fix the problems of the old system, we are not co-creating something new. And he challenged us to think differently. And we've had different messages here on this, and the importance of leadership and vision. You need to know where you're going. What does our future health system look like? And then we can leverage the power of networking together, our partnerships and the capacity, and we can move away from a reactive health system. There's a lot that we can do without changing the treaty. We could get better and smarter about the way we cooperate, about the way we regulate, about the way we share data and do that. So that's, our title was Health Union from Myth to Fact. For it to become a fact, we have to get better at what we do. So thank you all. Thank you as well for participating. We're going to take a half-an-hour break. For those of you online, we'll see you in half an hour, so we'll see you at 12:30. For those of you who are here, we're offering you a light lunch just outside and upstairs. Please be back promptly so we can start at 12:30, where we're going to talk AI and all things digital. Thank you. Welcome back, ladies and gentlemen, to our online audiences and people here. I hope you've all had a good chance to eat something, refresh yourselves, because in this next part, we're going to ask the question, can the digital single market cure European health systems? We talked a lot before the break about the importance of changing our mindset and shifting what we do, the way we do it, and thinking about how the different components of everything that we have, because as Boya reminded us, we've never had more money, more people, more skills, more technology. So how would we put all of those elements in place to deliver better health outcomes for our population? And let me just introduce our panel briefly, and then we'll get into the topic. So I have Ricardo Baptista Lete. He's the CEO of Health AI, also a former European young leader and a former member of parliament, and of course set up Unite, the Global Parliamentary Network for Health. I have Virginie Boulous-Fassa, the CEO of Eurodis, the network of rare disease patients. I have Teresa Conceição, who is the head of global operations of data, privacy, digital and AI for Novartis. I also have Jeanette Edblad, the Deputy Director General and Director for the Swedish Offices of Life Sciences, and Tomislav Sokol, MEP and member of the Public Health Committee. So we have a really broad set of expertise and knowledge here on the panel. But let me start with you, Ricardo, because we've talked a little bit about AI, and this morning there was even more conversation about, the future of neurotechnology. So we have huge hopes. Europe is setting a lot of store by, using AI for the future. But, is it ethical? Is there such a thing? How would AI potentially transform what we do in health? So I'd like you to just set the scene, and if you can, give us a few challenges and where the opportunities lie.
All right. Thank you so much, Tamzin, and good afternoon, everyone. In academia, we call this the graveyard shift, right after lunch, and so trying to keep people awake is a challenge. We'll do our best. I'm a Catholic, and as a Catholic, we believe in commandments, and I've come up with the 5 commandments on how to manage properly a health system. And those are, as Catholics, the commandments are telling us what not to do. These are things we should be doing. And so if you're managing a health system in whatever role it is, if you're not doing one of these 5 things, you better stop and ask yourself, why am I doing this? So 1 is prevention. If it's a preventable disease, prevent it. 2 is cure. If it's a curable disease, cure it. If it's neither preventable or curable, you should at least manage it properly. A chronic disease, for example, that isn't preventable. And if a person is in end-of-life care or with chronic pain, minimizing suffering and malaise, that's also extremely important from a compassionate, humanistic perspective. And the 5th commandment is efficiency, at least. So even if you don't do any of the above, but at least for the same outcomes, doing it at a lower cost is equally important. The thing is, this seems pretty obvious, right? That we would be doing one of these 5 things. The truth is, 20 to 40% of expenditure in health systems today are being spent on things that contribute 0 to better health outcomes. So that means we are spending globally around $3 trillion in things that are absolutely useless in health systems. To put that in perspective, the European Union budget between 2021 and 2027 is $2 trillion. So we're always complaining there's no money. Let's start there. And so when we talk about ethical use of AI, we can even think about what we are doing within our health system, is that even ethical? But going to the point, and I think Bogi really framed the whole discussion very well, then reimagining what the future should look like, well, we understand then we have to lower the burden of disease, focus on outcomes, and we need to address at the patient, at the individual, at the citizen level, how can we improve, not only react when they get sick, but how can we improve their quality of life and well-being? And what affects our health status as individuals is quite unique. As a doctor, when I have a patient in front of me, I'm only looking at 10% of what affects their health, the clinical factors. 30% of what affects our health are biological factors, our genetics. 60% of what affects our health are exogenous factors. Where we live, the air we breathe. If I decide to go to McDonald's after this seminar and have lunch instead of eating a salad, our behaviors, our decisions. All of this represents 60%, yet it is absolutely ignored by the health system. Those 60%, actually all of that, 100% of things that affect our health, represents terabytes of data. That until now we have not had the computer capacity or the technology to address and to transform that data into information, that information into clinical practice or into policies. AI represents that opportunity. And within the European context, the European health data space represents an opportunity for Europe to leapfrog into a future where this brings economic advantages, where we can actually leverage the power of AI to redesign our health systems altogether, to use AI not to rethink, not to continue to do what we're doing now at a faster pace, promoting more inefficiencies and insustainability, but actually how do we use AI to address the issues of outcomes more efficiently. So we were hearing a discussion in one of the parallel sessions this morning. So we need to invest, should we invest more in technology? Should we invest more in health workforce? Should we invest more in hospitals? And at the end of the day, you should invest on what will bring the best outcomes to the population. Full stop. And that has to be our obsession, our mindset. The mindset shift that Bogi was mentioning is exactly that. We are so trapped within the current model of sickness care that we have lost focus, that we're pumping in money into systems that will not change if we don't fix the incentives model behind it. AI can be the driver for that transformation, but that demands leadership. AI will not be the solution for everything. Humans will. AI will only take us where we want the AI to take us. If we have leaders who have no idea where they're going, it won't be the AI to save humanity. So we need leaders that have a clear vision of what the future of health and care should look like, and then we can use AI to take us to that next level. I believe that's a challenge we have at hand.
Thank you very much, Ricardo. I think you have set the scene for our conversation really nicely, which is, if the key objective, the purpose of our health systems is to keep our population as healthy as possible and to deliver the best outcomes, then that becomes the criteria through which everything is seen. And AI, it has a role to play in it. It's not a fixer to a broken system. It is a tool to be more efficient, to do no harm. That wasn't quite in your list of commandments, but I had it in my head. So Virginie, let me bring you in now, because for rare disease patients, the vast majority of them, there is no cure or treatment that's being offered. But there is a range of different things that technology and digital tools could help them with. But it all is about patients having space, an opportunity to engage in a meaningful way to help shape decisions that affect their lives and that of their families. So can you give us a sense from your perspective and the perspective of the rare disease patients and their families, how can patient engagement and digital literacy support meaningful participation in some of the big things that Ricardo talked about, AI and big data initiatives? Fantastic, but let's talk about the patients.
Thank you. Thank you very much. Well, I think, often maybe engagement and digital literacy are seen as add-on, but they're not. They're really essential components of a broader system. And if actually if the health system fail to really engage patients, then they will exclude those who need them most. So it's really important to also understand that people living with rare disease are highly motivated to contribute to patient-driven initiatives. And I just wanted to use also the example, but the evidence actually that we got, because Eurodis often launch quantitative and qualitative survey with the rare disease patient communities. And we did one a few years ago, which actually we published also the result in a peer-reviewed journal so that it could have a wider impact. But on the perspectives of rare disease patients when it comes to data sharing initiatives, whether it was in healthcare or research. And 80% of patients really want to participate and to share their data for rare disease. But even more striking, I think, is so they want to do that, but obviously, with some safeguard in place, and they want to retain some level of control. But interestingly, 95% of them are willing to take part in those initiatives, even for, if he can help understanding diseases other than their own. So that does mean that control and sharing are not opposing goals, but they're really like twin imperatives. And so I think it's really important to understand that what patient needs really is clarity. We talk about inclusive health, and that also needs to be included into the digital transformation. They need clarity, safeguards, but also, as you started, support to do so meaningfully. So if we want to prepare for an inclusive participation in the European health data space, that will require really the EU to invest in the whole rare disease data ecosystem, and specifically to provide support for, and I think it was mentioned earlier this morning, to support health data quality at the source. That's the first one as well, and that means we need to train healthcare professionals to help them to meet the legal, the semantic, and the organizational standards as well from the outset. Obviously, we need to enable patient participation and because they're often involved in other initiatives like registries, for example, or even expert centers, so they can scale up meaningfully as well and ensure the long-term sustainability. But I think also one point that is really very important to understand when it comes to rare disease. So our epidemiological data are not very good. Actually, we only have data for 60% of the most prevalent rare diseases. And as you can imagine, if health system cannot identify the patients, how can they then really assess whether the policy address the needs of the patient? They don't know what those needs are. How do we can really make decisions then on resource allocations? And so it's really important to accelerate and support the implementation of coding classification like ORPHANET, specifically when you talk about EHDS and including ORPHA codes in electronic health records. And that's also when patient will be able to be identified, to be seen and recognized. Then we can actually develop also target and metrics that will enable us to measure the progress of those digital transformation.
Thank you. Jeanette, let me turn to you because you are the director for the Swedish Office of Life Sciences, and I'd like to find out a little bit more about Sweden's life science strategy, the way that you leverage test beds and incubators and new tech like AI to accelerate the research and development that we need. Having seen how it operates in the national context, what advice, what lessons are there for Europe, which is planning its own life sciences strategy later this year?
Actually, it's been updated, so we had it in November 2024. Thank you for inviting me to the panel. Just to set the scene, Sweden's life science sector has around 4,000 life science companies, and they stand for around 10% of the total merchandise exports in Sweden. So no wonder that the Swedish government has a life science strategy since 2019, now updated. So life science surpasses even iron, steel, and automotive sectors. Just wanted to add that. Across regional clusters like Skåne, Malmö, Lund, Gothenburg, Stockholm, Uppsala, we see these vibrant ecosystems with science parks, incubators, and also test beds that collaborate with industry, public sector, and that is healthcare, and startups, of course, And this really helps turning research into real-world impact. Very important meeting places. And the government has also invested in public-private partnerships for innovation hubs, mostly on ATMP. So these regional clusters are essential for supporting innovation, for fostering collaboration, I'd say, both nationally and internationally. And they also produce their own regional strategies to support the national strategy for life sciences. I also like to comment on data. We need a more data-driven approach to health. We've talked about that. We're also seeing this clear trend towards data-driven life science and other sectors. But to build this health system that really prevents disease and promotes well-being, we must harness data on several levels, multiple levels, and across multiple sectors. Think about biological through advanced molecular diagnostics and also imaging, of course. Environmental and societal. We need to integrate data on pollution, green spaces, education, and food systems. And on the individual area, using wearables and digital tools to empower people to manage their own health. But this vision requires more than just technology, as we know. It requires a common interoperability framework. We must ensure that data is produced, structured, made accessible, and safeguarded across borders and across sectors. EU's ambition to harmonize data governance is very much needed, and it's essential not only for health, but for competitiveness, resilience, and innovation across Europe. Sweden's long-standing experience with national registries, national quality registries, built and maintained by health care professionals, demonstrates this power of structured data to improve care, to drive research and generate new knowledge. And building on this kind of expertise, combined with better utilization of advanced technology and all these advancements, we can here have a really significant opportunity, I think.
Excellent, thank you. So it's clear that the power of networking, bringing different organizations, structures, researchers, universities, and clinics together, produces this large amount of data. But you've got to be able to use it. It's got to be categorized, indexed, and then agreements on how to do it. And it's only then, when all the elements are in place, can we start to liberate some of the value that will come from that. So thank you for that. Teresa, let me come to you, because you are at the head of global operations for data privacy, digital and AI at Novartis. So you work with governments all around the world, lots of different jurisdictions. Now, Europe has a commitment both to universal healthcare, that's one of our core values, but it also wants to be the lead regulator to make sure that AI is delivering for human benefit. With your experience and the conversations you're having with regulators and policymakers all around the world on AI, what advice would you give to the EU? And this is important because, if we get it right in Europe, then it unlocks this position where we want to be, the world leader in our life sciences and everything else. There's a lot of criticism of the EU is it tends to over-regulate and it looks too much in the detail. So what would you like European policymakers to draw from your experience of other parts of the world?
Thank you so much for the great question, Tamsin. Hello, everyone. Let me start by saying that I am a lawyer by education and I work at ethics, risks, and compliance. So I have definitely a humanistic approach. And I also have a preference for laws and regulations because I understand how they are here to protect us and to guide us in a responsible way, of course. This is my personal opinion. So I must say that working in a multinational pharmaceutical company, we look for in multiple jurisdictions, in multiple regions, but we start with foundations of ethics, of responsible data. So we have a basis of a code of ethics, of course, applicable equally to all of our employees across the world. We then deep dive in policies which set standards with principles, and then we work with cross-functional teams. So we have multiple perspectives, and I bring this multiple perspective because this is exactly what I would expect that in Europe and worldwide, globally, we look in the multiple perspectives. We have 27 member states and we have multiple countries. So, but regulations is here to support us. And ultimately, we should think that technology, and AI in particular, is here to serve humans. It's here to serve people. It's not the other way around. So this is the responsible principle that we start with having a respect for humanity and putting people at the center. And this is also very true in the healthcare space. Obviously, we put patients in the center. Then, of course, we need to gather data, to use data responsibly, to make sure that we are transparent. And we have been hearing about this in multiple sections, including in the first one that I was in the morning, which is the trust. We need to gain trust and to continue to maintain the trust. And then we need to be able to make data mobile and have the data fluid across certain and different regions, because this is where we look and we understand that we are a global society, which we are. So when we think about the different legislations, we have legislations touching data privacy, personal data, European health data space, we have the European AI Act, and we have also the US bulk data. We have legislations in China, we have legislations in South America. So how do we bring convergency to all of this? So in a general speaking terms, I would advocate for co-creation and collaboration of understandings of concepts, like scientific research. We touch upon scientific research in personal data protection law. We touch upon it in the European AI Act. And it's important to have the regulators giving their understanding of what are the concepts and how they want to move them forward. Driving convergency, including within the European member states, because it's not just one privacy regulator, it's the European AI office, and it's also the ethics committees, it's also the hospitals, and then there is the patient. So what do we mean by all of this, and how do we bring this all together so that we can have actually fair representation of the data and of the population that needs to be identified, so that actually we can bring medicines to them in an adequate way. So in a nutshell, I would say that it's the constructive dialogue, being mindful that we are here with a responsible and ethical approach to gather the information so that to gather the data, to convert it in information that can actually serve the patients and humankind in general. So this would be my contribution.
Thank you. And just before you pass the mic, the earlier panel talked with great concern about the reduction in clinical trials happening in Europe. And when we talk about a digital single market for European health, that surely should be one of the great benefits, is that we can offer at scale an opportunity to do clinical trials across country borders. We should be able to recruit patients, monitor them, and follow them. When you're looking in your own company about where to site your clinical trials, how do you assess Europe as a place where you have the data available, that you're able to sort of recruit and track and monitor patients? Is that an area where we've got things right, or are there still things you'd like us to do?
I think that there is always room for improvement, okay? And I think that we always should apply technology to serve it. So focusing on AI, there is the great opportunity to leverage, and there are tools already being developed that support the clinical trials to identify what are the best trial sites to deploy the clinical trials and to foster the recruitment of patients. Ultimately, this contributes for clinical trials being faster and being achieved, and the results being achieved faster with more efficiency. So this is one thing. I would not have the numbers to understand exactly where the clinical trials are being selected. That's not my line of business, so I don't have a straightforward answer to you, but I do have the answer that AI is being leveraged with the data responsibly, of course, to identify how to foster and to bring clinical trials to an end faster, because this only supports patients, because this means that the medicines will be available for the patients who actually need it faster. And let me just add it that the big question maybe is how can AI deliver more productivity? And I believe that that's yet, and my personal opinion is that is yet to be seen, because you probably all know, because we are talking about healthcare, but it takes 8 to 10 years to conclude clinical trial and to put a medicine into commercialization. So here is where, going forward, but again, it's still ahead of us. We would have the opportunity to leverage technology to serve humanity and humankind, so that actually you understand faster what are the success of the medicines being developed and therefore delivered to the right patient.
Thank you. I'm going to bring in our last panel member, then I'm going to open the floor to you, so be ready to have your questions and comments. Tomislav, you, of course, the European health data space was your particular area speciality. I believe you're the rapporteur for that in the European Parliament. We've got big hopes for that, but we also talked in the earlier panels about the fact there's huge inequalities across Europe. We've got big countries, poor countries, richer countries, less well-resourced countries. So access to care is very different across Europe. How do you see the EHDS and the EU investments in AI changing that to the better?
Okay, thank you very much. So there are a lot of things that we can do on access. So I think I have to go broader than that for what you can do. So first, when you speak about access, just one piece of information. Out of new oncological medicines which were approved on the centralized EU level by EMA and European Commission, within 1 year after the approval, 46 out of 48 were available in the biggest member state, while only 3 in Lithuania, for instance. So that's the ballpark. That's the context. So definitely differences are enormous. Also in terms of health outcomes, generally between Eastern and Western member states, Southern and Northern. Generally, it is to a large extent connected to the financial capabilities of the system, but not completely. So definitely there are big possibilities, a lot of things that we can do here. I'm glad, for instance, that the Council yesterday has concluded their part of the negotiations on the pharmaceutical package, where we introduced, and I hope that will soon start the negotiations, the obligation to provide medicines, and that was the Parliament's position, within 1 year after request. So each member state which needs a certain medicine makes a request to the pharmaceutical company, to the developer, and then they have 1 year to put it on the market of that member state. Otherwise, they face penalties. So I think that's something very concrete that EU is doing to try to increase access. I think that's the most direct thing that we can do in terms of increasing access. Second thing is the rules of cross-border healthcare. So, and these rules of cross-border healthcare that we have in the EU are very complicated. So we have 2 pieces of legislation regulating the same thing, directive and the Social Security regulation. But it's extremely complicated. It has reimbursement rules, but they are different. Under one set of rules, you can only access public providers. Under the other set of rules, you can also access private providers, but you have to pay out of your own pocket and ask for reimbursement afterwards. And also, under both sets of rules, you cannot access clinical trials abroad, because it's explicitly stated that you can only access those treatments abroad which are covered by your own domestic health insurance legislation. And health insurance legislation, by definition, only covers already approved treatments, and not those which are in the phase of clinical trials. So that's also one problem that we have in terms of, and one of the reasons why clinical trials are so concentrated in 3 or 4 biggest member states, especially Germany and France. So also by changing these rules, making them more flexible, having separate provisions for clinical trials and access to clinical trials, making them simpler, getting rid of this having to pay out of pocket and then asking for reimbursement without having everything paid straight away between health insurance funds or between health insurance fund and the healthcare provider abroad, we can really do a lot. So these are very concrete things that we can, the most concrete things that we can do on equality of access. In terms of EHDS can definitely play a role in terms of equality. It will make it possible for researchers from even smaller member states, from smaller research institutes or smaller universities, to get access to much more data than they have at their disposal. So researchers from Zagreb, where I'm from, in Croatia, will now be able to access systematized structured data from Germany, from France, from Sweden, from Italy, Spain, etc. So this is an enormous opportunity because it creates level playing field between all the researchers across the EU. And of course, this can also translate into research results and health outcomes themselves. Also, one thing where we need more level playing field when we speak about data is in the development and the level of digitalization itself across different member states, because we have enormous differences. And it's not only about financing. So, for instance, you have Finland, Estonia, countries which are well known for their digitalization, but you have, for instance, again, the biggest member state which is not that well ahead in terms of digitalization. A lot of things are still written on a piece of paper. So also there, if you provides financial assistance, if you do it right within the next 4 to 5 years of gradual implementation of the whole thing, to prepare the system, to build trust in the system, and to build trust first, you have to inform everybody, workforce, healthcare professionals, patient associations, etc., about what this is. Because, to be honest, 99% of people in our healthcare system have never heard of EHDS, even though it has already been adopted and negotiated, etc. I mean, healthcare professionals, not to mention patients. So definitely informing them, training them, preparing them, building trust, building digital infrastructure, also preparing national implementing rules in some cases, and the system. So all of these things need to be done in the next several years if we want to prepare the system to actually, that it actually makes sense that it is implemented. And I think here this will be very important, especially for patients suffering from rare diseases, because still 95% of patients who suffer from rare diseases do not have a treatment, which is enormous, because when we say rare diseases, people think, okay, that's a small number of people. But if you take all of them together, more than 6,000 rare diseases that there are out there, more than 30 million people in EU are suffering from them. So it's a big public health issue. But since it's so many of them, so many different rare diseases, definitely our research focus should be there, because the biggest untapped potential, the biggest problem, I think, is definitely in that area. And I think here, EHDS, by untapping the potential of this data for research, but also of tracking health outcomes and clinical trials, etc., and bringing real-world data, can also help health outcomes and better efficiency, what Ricardo mentioned, of the health system in general. And just one last point when we speak about investments in healthcare. I agree that there is a lot of inefficiencies. You covered that very well, but still, if things are done right, €1 invested into health system can bring up to 14 euros of return on investment, in terms of innovation, development of technologies, but also better productivity of the general population, which is good for the economy, etc. So it's also important that we speak about investments into healthcare. We don't see it as just a cost, putting money down the drain, but actually as an investment that really has good return if you do it in the right way.
Thank you. So the panel members have set out, different perspectives and views on this. Let me open up to see if I have a question from the audience or online to say, the question we're asking: can the digital single market cure European health systems? Or we've had different messages, ways forward, looking at regulation, we're looking at data movement, looking at retraining and rethinking what we do. Is there an intervention I should take? Because if not, I've got loads of questions for the panel. So don't feel like it's necessary. I'm quite happy to take it forward. And Ricardo, maybe I'll start with you while people are thinking. You mentioned that up to between 20 and 40% of spending in healthcare isn't delivering any measurable health benefit. Maybe you could give us 2 or 3 use cases where you can say AI, the efficient use and deployment of AI would make a real difference. We heard in the earlier panel that we can use technology to reduce the paperwork and admin that clinicians are doing, freeing them up. We've heard that it will do things like, reduce the overall stress and the number of false alerts they do. Just help us because for so many people, we don't really know what AI is. So if you could give us 2 or 3 concrete cases where we say, here's where I can see AI will take that 20 to 40% of wasted money and turn it into real value.
Yeah, I mean,
We'll just change the microphone, thank you. Go ahead. Is it on? It should be on.
All right.
Go ahead.
All right. Okay. So I work with AI, and I always end up with the technological glitches. So there are many examples that one can use. Imaging is by far the area that already is not. So we talk about AI many times from a future perspective. It's a reality today. And I can share with you how, for example, in breast cancer detection, AI tools are being used in imaging technology, being able to detect breast cancer 5 to 7 years earlier than with human oversight of the same imaging technology. That is quite impressive. That means saving lives. That is making much more efficient outcomes, saving money also in terms of treatments and so forth. But one of the companies that I met in the UK that has developed technology in this space went bust. And they went bust because the UK regulators told them that they would take 7 years to assess the technology before they could even start discussing reimbursement. So when we talk about ethics, is this an ethical approach? This is a huge challenge. And so it has raised many issues. For example, how ethical is it, when in the regulatory space, you compare typically the technology you have with the gold standard, right? And the gold standard in many contexts, not just in low and middle income countries, even here in Europe, is not available. But you have an AI tool that is accessible, ready to be deployed in the community, versus nothing. Is it ethical to hold back because it does not live up to the gold standard? And so this is another huge issue to be discussed. But there are other practical examples. In my country, Portugal, there was a study that showed that 60% of the patients who left the doctor's office didn't understand what to do in terms of follow-up. And we've all been there as doctors, where the patient says yes to everything, and then they have no idea what we said. And so a small hospital in rural Portugal launched a virtual chat assistant that would call patients after they left the hospital. And so a patient I met, 80+ years old lady, she left the hospital after being discharged with heart failure. And so she went home, and she would get daily calls by this virtual assistant, reminding her of the exercises she needed to do, the medicines. It led her to be retained to care, to comply with her medication. And when she went back to the hospital to the doctor, she told the doctor, "Listen, doctor, I just want to tell you, this new person you hired, she's the kindest person you've ever had working here." And then they told her, it's a robot. And she says, "I do not care." And so, but that's a very interesting case. And there was a paper published in JAMA that compared a virtual chatbot. Patients would write to the computer asking for assistance. They thought they were talking with doctors. Half of the responses came from robots. When they looked at outcomes, the health outcomes were better with the robots than with the humans. But then when they asked the patients who showed more compassion, the robots won again. And let that sink in for a second, right? So we are dealing with a reality where the machines have more time and patience. They can stay all night talking with you. Doctors have 15 minutes to do everything. And so there are huge opportunities there. But then, if I'm a doctor having to decide chemotherapy for a cancer patient, right? And I have a clinical decision support tool that is telling me, do this combined chemotherapy. As a doctor, as a citizen, I might think twice. I don't know if I'm going to trust a machine. But when I have a fever, I'll take a paracetamol without thinking twice. Why is that? Why is that trust factor there? It's because during decades, we've built a system built on a regulatory system that has led us to trust the technology and to use it. We are not there yet. We're far from it. And that's why we see a lot of pilots when it comes to AI, but we're not seeing systemic transformation. The scaling part, and that at Health AI, we're working with governments helping precisely to build that governance capability. And so if we're capable of doing that, we will be able to accelerate and scale these technologies. And so unlike what we many times hear in the technological field, health is very different in the sense that innovation is impossible without regulation. And what I mean by this is that you can have an amazing technology, you can even build a pilot here and there, but if you want to scale, you need to have reimbursement. You need the health system to uptake, or the insurance company to uptake it at the systemic level. And you need, for that to happen, you need a system where you are capable of assessing the technology, of validating it, and defining how to do the health technology assessment. That is not in place for much of this technology. And so instead of always provoking this debate around regulation and innovation, it's addressing, in Europe we have, Tomislav spoke eloquently about the EU Act and about the EHDS and all of these huge opportunities. Let's embrace what is being done in Europe to give us a leading advantage so we can scale these technologies and have as a clear ambition the systemic transformation and redesign of our health systems, becoming the de facto benchmark for the rest of the world while serving towards a better and healthier future for the European citizen.
Thank you, Ricardo. It's very, when you describe it, it's very clear what needs to happen, and it's really lovely to hear that AI is using AI. It's possible to retain the human connection and the emotional support that's so critical within health. Because there's such a fear that AI equals robots, it equals impersonal care, and we've lost that personal touch. So it's great to hear that it's providing some of those software elements.
Just on that component, because I think the humanistic focus is lost many times in the conversation. We can actually use AI to bring the human factor back in. So in Malaysia, chatbots allowed many more people with HIV to step up because they're afraid to talk to their healthcare practitioners because of the laws in place. But they felt much more comfortable talking with the chatbots. So getting more patients into care, or even in mental health. We're having a true mental health or a mental disease epidemic, especially among our youth. The capacity of these tools is tremendous, but once again, we need to make sure that technology is effective and safe. The responsible use of AI is a prerogative, but if we get it right, it can be truly transformative.
Thank you. Teresa, you were nodding a lot when Ricardo was speaking, and I think when he sort of said, in healthcare, you need regulation in order to have innovation, and I'm sure that's something that you come across in your experiences and your dialogues. What would you like to add?
I totally agree that innovation requires regulation, and regulation is here to support it, not to prevent it. I would add that I would reiterate what I mentioned about the constructive dialogue, the openness of regulators to address the topics and the projects and the new technologies going forward with the private sector, as with the academia and the hospitals, understanding the need to have these open conversations so that we can actually deliver jointly. Okay, so the cooperation is key. Between the private sector and the regulators, the government, and having this convergency, because we talk about the European health data space. I talked about the general data protection legislations, the European AI Act. We have the same we have the same concepts in all the legislations, but they slightly mean different things, or they are actually not even defined. So there's room for interpretation, but I would left the rapto, if I may, that we are all coming from a good place, and if we have constructive dialogues, we're going to reach good outcomes to deliver to society and to patients in particular. So this is what I would add. And we set the tone. The Brussels effect is also here. A lot of countries follow. They followed it in the GDPR. I think that the harmonization and the standardization, so that it's easy for the startups, the biotechs, and also the big pharmaceutical companies and the hospitals to navigate through all the regulatory landscape. Don't get scared, and you don't drive the exact opposite in the rest of the world, because the GDPR had that great effect. Let's leverage the European AI Act, the first enacted legislation, to actually achieve that consistency globally.
Thank you. Yes, let's just give you a microphone. But you set as many challenges in your first opening messages, so have we met some of them?
Another one. So just a curiosity question. So digital single market to cure the European health system. So this is a frame. So there is this old concept of data intent. So if you have data that can provide value, you cannot just sit on it. Most data you can say, even if it's in commercial hands, derives from something public. The World Bank has begun to push this in low and middle income countries again. So is there also a concept of that we need to, when we harvest data, we actually have an obligation to use it? I'm not saying 100% that has to be done, but we are only utilizing 3% of health data today, and that's a challenge. So do we need to be more, to set a standard on produce to use? Because Ricardo, in the AI, I'm fully in with you, but crap data doesn't work for us in that way. So is that what we need to do in order to really push and get all activities? And just being honest here that a lot of the data on the commercial hands is not opened to the rest of us, but it also goes for the public data in universities. So how do we push that one?
Jeanette, I'm going to put you on the hot seat for this, and then I'll come to Tomislav, because these questions, if we've got data in our health systems, we should have the obligation to use it so that it delivers outcomes for patients, it delivers breakthroughs, etc. But so much of it sits in silos, protected. Some university departments want to keep their own databases, etc. How do we make the data flow? And looking at it from sort of a national perspective in Sweden, have you cracked that nut? Have you managed to, increase the use and reuse and flow of data?
I don't think we have, actually. I've also learned that we have maybe to produce even more data than we do today. We don't use it, but we have to produce more. I was thinking about another aspect, because that is a really tricky question, and I'm not a politician, but I was thinking about societal engagement to solve all these questions we're talking about today, all the vision we have, everything we want to achieve. Maybe we have to start with the societal engagement and the understanding of what health and life science is on the street, so to speak. For people to be willing that their taxes are used for these things, maybe, and also data goes with the same thing. To understand what makes me healthier, what has research to do with this. So just wanted to add that aspect. I think the first panel touched upon that as well. How do we engage people to get the investments, to get the engagement? I think that is one aspect of this. Very important question.
Thank you. Tomislav, let me bring you in because, the European Health Data Space and the AI Act, they're enablers for the data to flow, but often data just sits there and people don't use it. And we've had this message that there should be a moral obligation if we're generating data, and a lot of it comes from public systems, it should flow, it should be used, it should be accessed and made to work.
I would like to maybe just make some things clear. So EHDS is a binding legal rule, it's a binding law, with clear legal obligations, clear legal duties. So it's not a moral obligation. So if somebody fulfills the requirements to access data, then you have to give them access. So it's not your decision to make your discretion, etc. I mean, that's maybe that's something that hasn't seen. I'm not speaking to you, but in general, maybe there are some people who still don't quite get this concept. So I want to do so. Providers, data holders will have to structure data, systematize them, catalog them, make these catalogs available. If I'm a researcher, I want to do a research on pancreatic cancer. I will look for it, see that there is data set in Germany in the hospital that can be useful for me. I make a request to a public body in Germany, health data access body. I state the purpose for which I can use it. I cannot use it for anything I want. Purposes are clearly defined. And then if conditions are fulfilled, I'm entitled to get the data. So it's not a moral obligation, it's a legal obligation. I think it's very important to understand that. But precisely for that reason, it's important that we prepare the system, that they know how to do this and how to manage it. Because if you do not prepare the system, then it will be a mess. It will be chaos. because, yeah, okay, now we have a request, so what do we do? Now we did, etc., etc. But this is a clear legal framework with clear legal duties, clear obligations, if certain conditions are met. So I think that's important. So, of course, we have to do a lot of things to implement this in practice still. Implementing acts, delegated acts, commission that commission has to adopt still on many concrete details, etc. We have, as I said, prepared the systems for the whole thing to work. But if we do it right, so the whole system should be clear enough, and it will be clear what legal obligations there are on providing of the data. But it is a clear legal system of clear legal obligations that need to be fulfilled in the end.
Virginie, let me come to you. For representing the rare disease patients and their families. You know, listening to what we've just heard about the power of data, its potential, the need to make sure it's actually used and to flow across borders, what hopes do you have for the Digital Act, the AI and the European Health Data Space? How do you hope this will make a difference for rare disease patients?
Yes, thank you. Well, I have a lot of hope. Hopefully, otherwise I wouldn't be here. And I do think it has really the potential to be transformative in the future. But, you know, also just to go back briefly on what you said and others as well. So obviously, rare disease patients, maybe even more than others, are really desperate for their data to be used. They are extremely willing to contribute to data-driven initiatives. And so again, it's about inclusion, but really it's about partnership as well. So really to integrate, so rare disease patient, but also representative of civil society within those data-driven initiatives, in the design of those, but also in the governance and in the oversight. And we have worked on specific project with specifically with a working group we call the Data Advisory Board that is advising us on several research projects, and they really are very keen on the notion of return on data investments, also as an incentive for those initiatives or to be more accountable. So I think, you know, we talked about investing and investment is important. So investing also in those framework that will help to comply with the legislation in terms of transparency and accountability framework. So I think if you engage with patients, with representatives of civil society, and have those framework in place, then there is definitely a lot of hope for those solutions to be truly transformative for the community.
Excellent. Time has run away with us. Our conversation was so great. In our last 5 minutes, I'd like you all to sort of give me one sentence for, you know, message for the EU. And Tomislav, because you're the last one on our panel, I'm going to ask you to just answer the question, can the digital single market cure European health system? So that's a very simple one. Ricardo, what's your key message to European policymakers?
I guess we can go with a hashtag, incentives to outcomes, and that would address Bogi's question, because, you know, the tax authorities in our countries, if we don't give them all the data that is needed, they'll get back to us. And there's a real incentive, right? The government needs that data, and they want to take as much money as they can out of the taxes and so forth. So in the health system, we need to put the incentives right. And we saw that in Portugal, in the primary healthcare system. And doctors would get more money if they complied with certain health outcomes. I'm telling you, they go after the data and they apply the data, and that leads to better outcomes. So aligning incentives to better outcomes, using the power of AI for the health system transformation and redesigning. Europe has everything in place. We have the legislation, we have the institutions, we have the leadership at the national level. We have a unique opportunity to take the lead, and we should take it.
Thank you. Virginie.
Thank you. My message to the EU, I think, on those would be to embed health across the EU policy frameworks. So for competitiveness, for digital transformation, and for security. Innovation and solidarity actually go hand in hand. They are not opposing, goals. And that was actually echoed by a recent report of the Partnership for Health System Resilience and Sustainability, and also by the rare disease community through the Rare 2030 Foresight Study, Investment for Social Justice. So it's not incompatible, and actually we talked about innovation and regulation, innovation and solidarity.
Thank you. Jeanette.
The benefits of the new technology will not just fall down on us automatically. We need infrastructure for training and learning. We need private and public investments. And we need a willingness to adopt. So we have to raise to this challenge, I think.
Teresa.
I'm going to leverage on that because I was thinking about literacy. Literacy, because it's a single market, but it's a fragmented legal framework and landscape. So literacy on all the legislations, literacy on the human resources that actually are navigating through them at the European level to talk to each other, apply balance and checks, the same way the private sectors literates itself and urges that everyone gets more knowledgeable and therefore more empowered to leverage technology and data to better outcomes in healthcare.
Thank you. Thomas Lav.
Yes, thank you very much. On the main question, I would say that I wouldn't call our health systems sick. I think they can be improved. But I think they are still some of the best in the world, and I think that digital single market has a great potential. First, we have to create a single market, which we don't have, which is fragmented. I'm also in the Internal Market Committee in the Parliament, so we talk a lot about this. But I think we are going in the right direction. So we are speaking about more efficient legislation which supports innovation and competitiveness, not hampering it. We are speaking now more and more about investments as well, different sources, how to use public funding to leverage private funding as well. So I think we are going in the right directions. I think things are developing in the right way. The only thing that I'm scared of a bit is that we lose health budget, separate health budget in the next MFF, and we have to fight strongly for that. So my plea at every conference that I attend on any topic now is let's try to put pressure on the Commission and on the national governments to retain the separate health budget, because we want health to remain a priority on the level of the EU. We need a separate budget and not something absorbed with different other things, because if this is the result, then the whole thing will be diluted and we'll go back to 2017, 2018 when healthcare was a marginal topic here. So let's fight for health budget, for EU health budget as well. Thanks.
Thank you very much. And I echo your call to say there was a step change in the last mandate, partly because the multi-annual financial framework was being negotiated as the pandemic hit. So we got 10 or 11 times more money for health than we'd ever had before. And where the money goes, the political attention goes, and we saw a big change both in the capacity and willingness of member states to collaborate and do things on health. And it's really important not to lose that, because it has created something that we can build on.
And just one thing, and we also saw that EU can actually provide an added value, that it's not only national competence and EU has no role to play, which was a standard mantra before. We saw that there are some problems like public health emergencies, I would add rare diseases, for instance, etc., where actually EU needs to solve problems which member states cannot solve by themselves. And this is why we need EU action. So EU cannot solve everything, but it can do a lot.
Thank you. So we had evidence of not just the theoretical added value of Europe for health, but real added value that could be felt in everyone's arm as they were jabbed with a vaccine in an equal way across Europe. So I'm now going to bring this panel and indeed the Sustainability Summit to a close. Can we say a warm thank you to these speakers and the previous speakers, please? Thank you very much for coming and being part of it and sharing your ideas. We hope you've inspired you and challenged you. That's part of the role and mission of Friends Europe. We hope to connect and engage in debate. So we will hopefully see you at another event very soon. Thank you and enjoy your afternoon. Thank you. Yes, I know you've got to cut my mic. You're welcome. Did you enjoy it? Yes. Good.